The focus of this presentation is on dysphagia in neonatal intensive care units, or as it's better known, the NICU. So infants admitted to the NICU are typically born prematurely, they experience difficulties during their deliveries, or they show signs of a problem within the first few days of life. It takes a multidisciplinary approach to treat these infants, and one of the members of the team is an SLP, or a speech-language pathologist. So the SLP's role in the NICU is to assess feeding and swallow function and to determine when infants are prepared to ingest nutrition orally. Feeding and swallowing can be negatively impacted by a lot of factors, which are including but not limited to structural deficits, a developmental disability, cognitive disorders, neurological disorders, and genetic syndromes. There's been a lot of research that shows deficiencies in feeding and swallowing function are related to sensory and oral motor deficits, which can be remedied by promoting the non-nutritive suck and a nutritive suck, and I'll get into what those terms mean a little bit later. So it's really critical for SLPs to have a deep understanding of the swallowing mechanism in infants in order to appropriately treat them for pediatric dysphagia. So admission of infants to the NICU is on the rise. From 2007 to 2012, there was a 7.8% increase of infants admitted to the NICU according to the CDC, and the number is still growing. The majority of infants admitted to the NICU are premature, and the World Health Administration estimates that about 15 million infants are born premature each year. So a premature infant is one who was born 34 weeks before gestation. Full term is a 40-week-old infant. So the biggest players that have increased survival rates in infants are technology and medicine. Because of the strides that we made, doctors are able to save very premature infants who would not have had a chance of survival many years ago. Infants who enter the NICU are considered medically fragile and require more medical attention than a typical healthy newborn. I think it's also really important to note that about $4.5 billion every year is spent on NICU services. So these infants are really expensive to treat, and they require constant medical care until they're medically stable. To be discharged from the NICU, infants have to be able to safely breathe on their own, and they also have to be able to ingest nutrition, whether that's through a tube or orally. They have to be able to eat before they can leave. SLPs are consulted in the NICU to assess feeding and swallowing function in infants and to diagnose and treat dysphagia. These are just some potential causes of pediatric dysphagia. An infant can be brought in with impaired neuromuscular coordination, which is prematurity, or they might have just a really low birth weight. There can be some kind of developmental disability, whether it's physical or cognitive. They can have a neurological disorder, so that could be like cerebral palsy, encephalopathy, and traumatic brain injury. Structural abnormalities like cleft lip or cleft palate, you might see those in the NICU, or any general head and neck abnormalities. And infants in the NICU might also have genetic syndrome, so Treacher-Collins or Pierre-Robins. This is just an overview of what a full-term pregnancy looks like in a healthy infant. It covers a lot of developmental milestones as it relates to breathing, sucking, and swallowing. So from weeks 13 to 16, a fetus can swallow in here. From weeks 17 to 20, the sucking response begins to develop. So that's the non-nutritive sucking response. From weeks 21 to 24, the lungs are fully formed, but they're not yet functioning. Weeks 28 to 37 is really critical for infant development, and like I said before, a premature infant is anything below 34 weeks. So if an infant is born prematurely, they're missing out on all of this development. So in this critical time, the lungs are maturing and they're getting ready to function in the outside environment. So the respiratory system in a lot of infants, a lot of preemies, is not fully developed yet. The brain does a lot of developing. Non-nutritive sucking begins to develop in strength and frequency, so that's when the baby really starts to get the rhythm of it down. And the suck and swallow response begins to develop around week 32, which is going to be important. That's how the baby is going to get their nutrition once they're outside of the womb. And then from weeks 37 to 40, the brain and lungs continue to develop. So you can see if a baby is born early, or is born with any kind of impairment, they're going to be missing out on a lot of these important milestones. So treating adult dysphagia is really different from treating pediatric dysphagia. Although the structures are the same, their placement and their size are pretty different. An adult who treats, an SLP who treats adult dysphagia patients is not necessarily qualified to treat an infant and pediatric dysphagia. Working in the NICU is a highly specialized set of skills. So as you can see from the image, in infants, the tongue fills the oral cavity and the velum hangs a lot lower than in an adult. The hyoid bone and the larynx are also positioned higher than in adults, and as a result, the larynx elevates less than in adults during the pharyngeal phase of the swallow. So everything in an infant is a lot closer together. Once the infant begins eating pureed food, each swallow is discrete, and the oral and pharyngeal phases are similar to that of an adult, although the larynx is still less elevated. As the child matures, the jaw grows down and forward, and the tongue also moves down. The space between the tongue and the palate increases, and the larynx and the hyoid bone lower, which elongate and enlarge the pharynx. So when an infant is sucking, their tongue takes up most of their oral cavity, so they have to manage their tongue so they can get any nutrition down the pharynx, so you don't want it to go down the larynx. If an infant isn't positioned right, or if an infant has some structural abnormalities, something can come back out the nose, and you might have nasal regurgitation. These are all things we want to stay away from because they're not efficient for feeding. So there are some terms that I mentioned before: a nutritive suck and a non-nutritive suck. A non-nutritive suck is when a baby would suck for pleasure. So for instance, if they're sucking on a pacifier, if they're sucking on their thumb, they're still strengthening the sucking muscles, but it's a non-nutritive suck because they're not getting any nutrition. When babies engage in a nutritive suck, they'd be gaining nutrition. So that's when they might be bottle feeding or breastfeeding. Sucking is a learned and it's not a programmed behavior. This is really important to note. Although infants have like a semi-programmed response where they know how to suck, it still needs to be practiced. And if it's not practiced, the infant will lose the skills. And that's what happens to a lot of infants in the NICU. So the rhythm is controlled by the brainstem. And like I said before, learning continues after the suck-swallow response is achieved. So even if the infant sucks and swallows a couple times, they still need to have a lot of practice at it to get really good at it. So the non-nutritive suck develops first, and the nutritive sucking or the suck and swallow response develops after the non-nutritive suck. When infants are deprived of sensory input to the oral cavity and lack the physical practice of feeding, their skills decrease. The primary reason that infants experience separate sensory deprivation in the NICU is if they're intubated for some reason. Any intubation prevents the infant from gaining sensory exposure, and like I said before, if you don't use these skills, you lose them. This is also true of oral and oral motor deprivation. If an infant is intubated in the NICU or they don't have significant strength because they're so medically fragile, they lose the skills in sucking and swallowing they may have gained after birth. So sensory deprivation and oral motor deprivation are two of the biggest reasons why there are delays in feeding and swallowing. And once an infant is medically stable, the SLP would be brought in after sensory deprivation and oral motor deprivation have already been experienced by the infant, and the SLP would come in and work with the child. So there are a couple ways that SLPs can facilitate sucking and swallowing. Readiness of eating orally is determined by the ability for the infant to maintain being awake and to coordinate breathing with sucking and swallowing. This is really important if we don't want the infant to aspirate if they can't properly coordinate breathing with their swallowing. But we also want them to get the proper amount of nutrition. So if they're not staying awake, they're not going to get enough food in. If they're too weak, they might be feeding for too long, and then it's just not beneficial for the infant at that point. So the first thing you would do as an SLP is facilitate the non-nutritive suck, which would be using a pacifier or an empty breast, depends how involved the mother wants to be in her infant's therapy. So the non-nutritive suck, again, would just be getting the muscles strengthened and kind of getting the baby some sensory exposure so that they could begin to nutritively suck. which is when they would be ingesting their nutrition orally. There are a lot of medical devices that you could use. One example is a bottle that coordinates breathing and swallowing patterns of the infant. So the infant is never getting too much fluid, and it teaches the infant to efficiently suck and ingest food. Feeding has to be a positive experience for the newborn in order to appropriately learn how to feed and swallow. So it's really important that the SLP or caregivers respond to infant cues, know when the infant is really tired or fatiguing, and to make sure that the infant is getting the proper nutrition and is properly developing the suck and swallow response. As far as clinical relevance goes, SLPs are really integral in treating newborns in the NICU with feeding and swallow deficits. These are just some of the roles that SLPs would have in treating dysphagia in the NICU. They might select different nipples for enhanced bottle feeding. So like I was talking about before, the bottles administer different amounts of liquid, so you might choose a different nipple for that. Positioning for safe and efficient sucking. SLPs would probably work in conjunction with OTs with this, but they still have a role in positioning the baby in the correct manner so that they are safely eating. The SLP could also work on cheek and chin support to increase the volume intake while the infant is sucking. And most importantly, I think the SLPs, one of their major roles is to work on external pacing, which just means that the infant is appropriately balancing breathing with their sucking so they're not aspirating on any material. So in conclusion, SLPs more recently have had an increased role in feeding and swallowing therapy in infants in the NICU. Increasing sensory and oral motor input is really critical to developing feeding and swallowing skills for these infants. So that's working on the non-nutritive suck, the nutritive suck, and working on their breathing and sucking coordination. It's interesting because a lot of people think that this comes naturally, and it does in a healthy infant, but in these infants in the NICU, they're so medically fragile and they're so weak that we kind of have to retrain those natural responses. So it's really important that SLPs are responsive to infant needs in order to facilitate positive feeding and swallowing experiences. On a closing note, infants in the NICU are a highly specialized and unique population that require an extensive knowledge of the intricacies of the structure and function of the swallowing mechanism. Okay, and here are the references. Thank you very much.